Bismillahirrahmanirrahim. Assalamualaikum and good afternoon. This is the last part of the lecture on obstructive lung diseases. I'll be talking on bronchioectasis. So, bronchioectasis is defined as a disorder that there is a destruction of the smooth muscles and elastic tissue of the bronchi or bronchioles. Okay, and what's causing this are a lot of inflammatory process because of persistent or severe infection, and eventually the bronchi and bronchioles will lose their ability uh, to 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 dilate and to what do you call it is to be able to move. Okay, they are not able to move the peristaltic activity, okay, of the airways. All right, so this is a cartoon of normal lung. Okay, this on the left side here is a normal lung, and the right side here the bronchoectasis. Okay, so in bronchi, okay, in normal bronchus, there's cartilage and there's smooth muscles. Okay, you got the epithelial lining here, and in normal airways, there is some normal mucus being produced to ensure the moisture of the airway lumen. Okay, so there'll be the movement of the air inside the passage is smooth. But in bronchiectasis, okay, there is increase of mucus production, okay, and also some epithelial damage, as well as some changes in the smooth muscles. Okay, remember the airway remodeling, so the same thing happened here. And obviously, there's a lot of mucus here in the lumen. It will narrow down the lumen, and this is when the patient will complain of short of breath. Okay, and also producing copious sputum. Okay, a lot of sputum being coughed out. So there are a few conditions that are associated with bronchoectasis. Okay, congenital or hereditary conditions. Okay, and the congenital or any hereditary condition will dispose patient to chronic infection. Chronic meaning they are susceptible to more virulent organism, and also to have recurrent infection. Example of this condition are cystic fibrosis, intralobar sequestration of the lung, immunodeficiency states, primary ciliary dyskinesia, and Kataganner syndrome. So read up what is Kataganner syndrome. Secondly, due to a severe necrotizing pneumonia, okay, whether it is only one single episode of very bad chest infection, or whether there is a recurrent episode of chest infection. Okay, and the organism that are involved will include TB, Mycobacterium tuberculosis, or Staph aureus. So this is a very virulent gram-positive Staphylococcus bacteria. Okay, viruses, for example, adenovirus or any respiratory virus, even HIV. And thirdly is the fungus. Okay, Aspergillus is one of the virulent fungus that can, if it's attacked in the lung, it requires a very high dose of antifungal treatment. Okay, third condition can be due to bronchial obstruction, which can be caused by tumor. Okay, this so the dilation will occur distally to the tumor obstruction, or the patient accidentally inhale or foreign body enter the airways. Okay, if it's not removed, it can cause bronchiectasis eventually. Mucus infection due to some sort of reason, whether the cilia is not working properly in the airways. Okay, and in this case, the bronchioectasis is localized to the obstructed lung segment. Any sort of immune disorder can also cause bronchioectasis in long run. For example, rheumatoid arthritis, SLE, inflammatory bowel disease, or post-transplant reaction because of the inflammatory process that occur in this condition. Or it can also be idiopathic without any obvious reason. Okay, after we excluded the other conditions that can cause bronchiectasis. Okay, and likely is due to dysfunctional host immunity to infectious agent, leading to chronic inflammation. So the pathogenesis, so this is from an article that I pick up from the respiratory medicine, okay, written by Chan et al. So pathogenesis of bronchiectasis actually is a vicious disease, vicious cycle. Okay, the cycle goes round and round and round. Okay, so what happens is that when the patient has an underlying condition such as cystic fibrosis, so the airway epithelial and the ciliary dysfunction are not functioning properly, and also there is a mucus hypersecretion. Okay, so you can see here is mucus. Okay, this is the goblet cells are producing a lot of mucus. Okay, that is one thing that can occur. Chronic infection. Okay, so chronic infection leads to inflammation, and also then it will stimulate the goblet cells to produce more mucus. So inflammatory process. Okay, stimulate more mucus production by the goblet cells. Okay, inflammation. Okay, inflammation here just now. The inflammatory cells. Okay, the inflammatory cells that can produce more interleukins. Okay, eventually it can also cause damage to the airway and end up with permanent dilation. Okay, resultant bronchiectatic airways, they are poor in airway clearance, okay, perpetuating to chronic infection, inflammation, and airway epithelial and ciliary dysfunction. So one of the major role in the pathogenesis is excessive neutrophil elastase. So these neutrophils produce this enzyme, which weakens the integrity of the airway epithelial wall, so meaning there will be destruction of the epithelial cells. Okay, and it also can induce the mucus hypersecretion and impair the neutrophil bacterial interaction. Okay, so these cycles is repeated every continuously. So and remodeling happens. So bronchiectatic is the end results. A simpler way of pathogenesis of bronchiectasis, okay, repeated infection, the decolonization of the bacteria, impairment of the mucociliary clearance, and destruction of the mucociliary and cartilaginous supporting structure, okay, the loss of elasticity, release of inflammatory cytokines by the inflammatory cells, or eventually patient loss of ventilation. So it's a vicious cycle. Okay, it continues. So the repetitive process will eventually destroy the supporting smooth muscle and elastic tissue. So they've lost the elasticity of the airways. Okay, and then there'll be fibrosis because the fibroblast has been stimulated, and eventually it will lead to narrowing of the bronchi. The smaller bronchioles become fibrotic and obliterated, so it's called, the condition is called bronchiolitis obliterans. Okay, this is another flow chart of the pathogenesis. So it's continuity. Okay. Right, so microscopically, so this is a resected lung from a patient who died of severe sepsis. Okay, so you can see here, it looks like a bit of hemorrhage, this paler area, this probably there is consolidation here. And this is the airways. Look at the airways, it looks, you can't see the lumen, so a lot of mucus in the lumen of the airways. Okay, another microscopic picture. So this is a specimen that has been fixed in formalin. So some area here, the bottom area here looks like almost normal lung. Okay, probably fibrosis in the periphery here at the bottom. And the upper part shows dilated airways. So these are the bronchioectasis. So microscopically, it is because of lot of inflammation. So this is the pinkish cells here. The purplish cells here are all inflammatory cells, and this is the bronchi. A lot of inflammation. This is the epithelial lining and the spas in the lumen. Okay, and we can't appreciate where is the normal glands or the smooth muscles, all heavily infiltrated by the inflammatory cells. All the pink cells are the inflammatory cells, most likely the lymphocytes. The close-up of it, so this is the remnant of the alveoli, so it's congested, there's a lot of blood also inside there. Okay, and this is the bronchus. Okay, another one here, smaller bronchiole maybe. This is the bronchus, bronchi here, and there's a lot of inflammatory cells in the lumen. So this is the pus in the lumen. Okay, and okay, the walls. Okay, this is a pus, and then there's a lot of granulation tissue here in the wall of the bronchi. Okay, this arrow show here. Okay, granulation tissue, just revise what is granulation tissue, look up what are the components that forms a granulation tissue. Okay, we go to the clinical part of it. So clinical presentations, patient will present with severe persistent cough. Okay, and the sputum has a foul smelling, sometimes bloody. Okay, and is precipitated by URTI, upper respiratory tract infection. Okay, the patient may cough a lot in the morning and produce a lot of sputum. Okay, because when they get up, the draining of the collection, pus collection and secretion goes to the bronchi. So so they will cough it up to clear the bronchi. Okay, patient will come with shortness of breath or topnia, unable to lie flat, and cyanosis in severe cases. All patients also can present with hemoptysis, especially when there's erosion of the blood vessels and fever because of the infection. Right, so management of this patient. Okay, again, history taking, examination, observation. Okay, you might observe that the patient might have a bit of clubbing in the finger. Okay, this is club fingers. Okay, palpation, maybe some poor chest movement, percussion is hyperextender, maybe auscultation, lot of gargling sound in the chest. Okay, differential diagnosis, okay, respiratory or cardiac, so usual investigation. Okay, and this is the cartoon of it. Okay, the symptoms, hemoptysis can be massive, clubbing. Okay, and then you might hear high-pitched inspiratory sequels and rhonchi, okay, or local rhonchi, local crackles, and furious sputum. And as a doctor, later on, you need to look at what is the color of the sputum. Is it green? Is it black? Is it red? Is it yellow? Is there any smell? So you need to look at the sputum. Okay, just be careful if the suspected patient with TB, so you need to be careful. So investigation, chest x-ray. So in this chest x-ray, there is tram track sign. Okay, this shown here by the white arrows here. Okay, and the CT scan will shows some signet ring appearance. Okay, this is the thickening of the airways. Okay, so management. according to the British Thoracic Society guideline for bronchiectasis in adults, is first and foremost is to stabilize the patient, definitely give oxygen, make the patient comfortable, okay, and we need to treat the underlying cause, okay, and give antibiotics, give some support, bronchodilators, humidifier, nebulizer, oxygen, okay, and also get the physiotherapists to come and see the patient for chest rehabilitation. Okay, they have to learn how to clear up their lung by spitting out the sputum. Okay, advice on annual flu vaccination. Okay, maybe some patient needs to have prophylactic antibiotics to prevent repeated chest infection. Okay, and a few other steps here you can read up on your own. Okay. So what are the complications of bronchiectasis? It can be life-threatening, especially if the hemoptysis is a lot, okay, because of the erosion onto the blood vessels. Recurrent pneumonia, meaning recurrent ward admission, okay, because this kind of patient, they do not settle with just oral antibiotics. They need to be admitted for IV antibiotics. Also need to monitor the overall condition of the patient, such as the oxygen level, etc. Okay, patient also can have emphysema, pneumothorax, lung abscess, brain abscess. Okay, but with the advance of the more sensitive and accurate antibiotics, all these conditions now are a bit less compared to 20, 30 odd years ago. So in long run, patient can end up with lung fibrosis. Core pulmonale, because of lung fibrosis, the effect, it will also interfere with the vessels of the lung and end up with right side heart straining. Amyloidosis, okay, or resistant antibiotic resistant because of the repeated infection and repeated use of antibiotics, and the last one is death. Okay, currently better antibiotics and physical therapy, there is improvement of the life expectancy in patients with bronchiectasis. Okay, thank you.